So as I said at the beginning, we decided to try to cover, in past years we've sort of focused on one area like the spleen and looked at it from a number of different views. Here we're trying to sort of visit all different areas of the body, and in keeping with that theme, our next speaker is going to be Dr. Robison, our vascular surgeon, who you've been hearing for the last few days. And we've asked him to speak again on the comparison of open versus endovascular treatment for great vessel injuries. Dr. Robison?
Good morning. Thank you very much, Maine. So I think it's important when we talk about trauma that, especially the great vessels, that there are several principles involved, including resuscitation, early control of hemorrhage, debridement, repair, soft tissue coverage, and antibiotics are all basic principles in the management of trauma. And in terms of the aspects of endovascular approaches, these are the two things that we're most concerned about in terms of its applicability, is early control of hemorrhage and ultimate repair of the vessels. So I think it's important also to review some of the historical aspects of vascular trauma in terms of, we've learned a lot from war, and as Dr. Richard indicated earlier, from the Korean War, we've learned something. We also know that World War II, of all the thousands of arterial injuries, only about 80 were repaired. Many underwent ligation. In the Korean War, Dr. Hughes, who was alluded to earlier, reported 304 arterial repairs. And as we get better at it and using better devices, using vein, using prosthetics, the amputation rate in the extremities went down. But if there's a long delay, then the results aren't so good. This book by Dr. Norman Rich was really the Bible for vascular trauma when I was in my early training. And I like this all came out of the Vietnam Vascular Registry. I also like this drawing here. And this is a drawing from the book. I think vascular operative drawings are particularly illustrative, and I have a preference for doing this myself for many of our open cases, and I think it's particularly helpful. And I think this is interesting that this was included in Dr. Rich's book, and it also involves a great vessel injury, as you can see here. So these are, in Dr. Rich's book, the evolution of exposure, as you see here, from all the way from 1818 to 1969, through various approaches to the great vessels here, including partial median sternotomy. My colleagues, Dr. Schoenholz and Dr. Adams, all were editors on this recent edition of Vascular on vascular trauma, but I modified it a little bit to include great vessel injury here. So we're going to talk a little bit about the evolution and the approach in the application of an endovascular approach. And there's no question that over the years that endo has increased in use for trauma injuries, and especially in the thoracic aorta, which I'm not going to be speaking about, but in the carotid and both the subclavian area. So it still accounts for probably less than 10% of the management of these injuries. And the most common one that it's used in is actually in the carotid area, but occasionally but also the subclavian and rarely the innominate or even the axillary. Remember, there are several hard signs of vascular injury, including a pulse deficit, ischemia, hemorrhage, and bruit and or a thrill, which is evidence of an arteriovenous fistula. So physical examination is a very important aspect of the initial evaluation in helping you manage these issues. These considerations are all important, whether it's a blunt or a penetrating injury. How are you going to image it? How are you going to determine where the injury is and how to manage it? How are you going to fix it with a vein or prosthetic? Are you going to embolize it or ligate it? Whether there's an associated bone injury or neurologic deficit, We're going to talk about many of these injuries. We'll touch a little bit on iatrogenic injuries, but I'm not going to talk about pediatric injuries or managing venous injuries here. There are some of these mechanisms and pathologic injuries that are not easily amenable to endovascular approach other than to control hemorrhage, say transection or thrombosis with long segment occlusions and spasm. But many are. And I think it's useful to remember that many years ago, the big debate was whether to image patients or just explore them, and whether to do an arteriogram or not. And back when we didn't really have CT scanning, the big debate was whether everybody should have arteriograms. And we learned several things from that. One is that imaging was very useful in minimizing the rate of negative explorations. It used to be we just open the penetrating injury in a proximity area and explore it, and often it was negative. So angiography was particularly useful in minimizing the rate of negative explorations. And we also found that small disruptions or small intimal defects may actually not need any intervention. And overall, in penetrating proximity injuries, when there weren't any of the hard signs that we talked about earlier, that the incidence of significant injuries is remarkably low. So when you have hard signs, yes, you've got an injury. When you don't have hard signs, imaging can be particularly helpful. I think a current modern approach involves CT angio. We use it pretty liberally for both blunt and penetrating trauma. I don't think it should substitute for physical examination, but it may minimize the need for formal angiography, and it can certainly be helpful in assessing equivocal findings, and especially in the great vessels in the thoracic outlet. Duplex ultrasound is probably more useful in the extremity rather than in the great vessels, though, but it's good to keep that in mind. Angiography does have a definite role as an adjunct to CTA, though. It certainly facilitates an operative or an endovascular approach, of course, and allows access for endo intervention. The question is sometimes where best to do that. Not everybody has access to an angio hybrid suite in their operating room. And so where do you do this? Do you do this with a C-arm in the operating room, or do you do it in the angio suite? Or increasingly more people have access to these capabilities in their operating room. So how many in the audience think that this might have resulted in a significant arterial injury around the thoracic outlet? So I think that this is a gunshot wound, shotgun wound like this is certainly helpful, but it's interesting that a CT scan, I'm not sure, would have been particularly helpful with all this metal pellets around there. Might not have been able to pinpoint the injury, but the arteriogram here is very helpful because most of this, as you can see, the pellets are way up there and away from and there's no significant injury to the great vessels in this area, which is pretty remarkable when you think about it. So proximity alone is not an indication for exploration. There are some times that arteriography is particularly helpful. I think for surgeons here, it would be a daunting task to take on this. It certainly can be done with an open approach, but it really lends itself very well to an endovascular approach. And it wasn't long after Dr. Perotti described his approach to managing such injuries in about 1999 that Dr. Uflocker and I were able to construct a Palmaz device with PTFE and use it in a patient that had chronic AV fistula about 5 years after his gunshot wound, and he had massive arm swelling, and we were able to manage it with a homemade device before there were any stent grafts readily available off the shelf. Very similar to this. I think you can see that this would be particularly useful. An endo approach would be particularly useful with a covered stent. It does not address the injuries associated in the nerve area, and in all honesty, most of the disability that occurs in trauma in these areas, both blunt and penetrating, comes from the associated neurologic deficits and injuries that result concomitantly. And of course, the surrounding hematoma is not well addressed with the endo approach. It does control the hemorrhage and restore blood flow. So this kind of thing, when you have an actual disruption of the artery, is probably best managed with a direct surgical approach, in my opinion. And in this situation where you have an open comminuted fracture of the clavicle with a poor motor function and a poor pulse in the right upper extremity, is also, and when, especially if they're going to plan open reduction anyway of this clavicle fracture, is probably best managed with a direct approach. And this is this patient, and if you follow along the subclavian, you can see that it's obliterated here. So that was directly managed with an open approach, and I would suggest that associated great vessel trauma associated with nerve, artery, and vein injury and a fracture is probably best managed operatively as well. In terms of the type of surgical repair, occasionally primary arteriography is appropriate, just suture repair. If the damaged segment is fairly focal and the artery can be mobilized proximally and distally for a couple of centimeters and you can resect the damaged part, then sometimes that lends itself to an end-to-end repair. And that avoids the use of any prosthetic. The use of a prosthetic is very helpful in the area of the great vessels in terms of less size discrepancy as opposed to vein, and it actually provides good early patency, and the incidence of prosthetic infection is fairly low. In terms of carotid and vertebral injury, fortunately these account for less than 1% of all arterial injuries. Most commonly, the carotid is a blunt injury and results in a local, in a dissection, a carotid dissection. The diagnosis of this is often delayed, although with more common use of CT scanning in the head and neck area, it's picked up more frequently. With carotid dissection, anticoagulation is usually the optimal treatment, but frequently this is not possible in patients that have multiple other injuries, although there's not any clear benefit to anticoagulation over antiplatelet therapy. Interestingly, many of these blunt carotid dissections will recanalize, and most, 90%, will have no further neurologic symptoms. So there's currently a debate about whether routine intervention for carotid dissection is warranted endovascularly. On the other hand, Dr. Bain-Selby and I remember a young man that had bilateral carotid dissections nearly 15 years ago. This young man had a pseudoaneurysm near the base of his skull that resulted in a pulsatile retropharyngeal mass that was symptomatic, and Bain was able to manage this with a wall graft, as I recall, requiring a direct arterial puncture. Now we have much more better covered stent grafts, but that resulted in an excellent outcome for this young man. And even though that wall graft occluded several months later, his contralateral carotid dissection completely healed, and he had no neurologic deficit even after he occluded his wall graft. That was back in the dark ages. So occasionally endovascular repair of the injury may be appropriate in the carotid. It certainly might be appropriate in the patients that have recurrent symptoms or persistent pseudoaneurysms, especially in the zone 1 or zone 3. And the question would be what stent to use. We would probably use one of the covered self-expanding stents in the distal ICA. There are some considerations for both the graft and the size of the delivery system, because the size of the distal internal carotid artery is a little bit smaller than we would like to use with our current covered stent grafts. You may hear from some subsequent speakers about the role for other types of stents in these areas, and especially the low porosity flow diverting stents that might be more applicable in the distal internal carotid artery. In the vertebral, there's a lot of debate about whether to cover those or just coil those. And then this is just a grading scale for blunt carotid injury. In all honesty, I think it's most useful for reporting purposes and not of really practical use, at least in the middle of the night when you're trying to decide what to do. For penetrating injuries in the accessible part of the neck in zone 2, open repair is preferred. It allows exploration and management of concomitant injuries that might have occurred in either the trachea or the esophagus. Such as this young 14-year-old victim of domestic violence who was shot in the shoulder and the neck, and the bullet entered in her left jaw and transected her proximal right common carotid artery. And this was managed with direct open repair, and even though on the CT scan, I think you can see there's a long segment of contrast absence right here, but the injury did not involve that whole segment of artery. So on exploration, we were actually able to get proximal control just above the clavicle, mobilize that artery, and perform an end-to-end anastomosis. That being said, the use of endovascular techniques to manage both blunt and penetrating injuries is increasing over the last several years. And I don't think it's a coincidence that the associated mortality with these injuries is decreasing from the 30 to 40% range to less than 20% over the years. So there are a number of considerations for repair: the size, the diameter of the artery, the length of the stent to allow sealing of the injury, and also to preserve collaterals. There's balloon expandables covered stents. I don't need to elaborate too much on that with this audience, but they do allow a little bit. The balloon expandable stents have a little smaller delivery system. The self-expanding stents require usually a larger delivery system, and you can think of the size of the stent usually requires a comparable delivery system almost equal to that. So a 10 millimeter stent requires an 11 French system. Their 13 millimeter self-expanding stents require a 12 French system currently. So those are all considerations in terms of access and delivery of these devices. There's one caveat I would encourage you to remember is if placement over the first rib and underneath the clavicle can be associated with compression of the stent and subsequent occlusion. So we try and avoid doing that except in dire circumstances. So I want to move on to iatrogenic injuries, because you may recognize a few of the authors on this paper that are part of the program here today. And things haven't changed in the many years since we put together this paper, but because doctors are still causing damage. This is the way that a central line should go into the vena cava, and it shouldn't go this way into the arch of the aorta. And the question is, what should we do with this? This is a central line access. Should it be removed with just pressure held on it, or should it be removed surgically or managed endovascularly? The technique of pull pressure observation works pretty well if the size of the sheath or the cordis introducer is less than 7 French. But if it's larger than that, in 30 to 50% of these, it will result in either symptoms or distal embolization or a pseudoaneurysm. So our practice is generally to leave that catheter in place. You can use some associated imaging. And then when it's in the carotid artery, our preference is to use surgical removal under direct vision. This allows distal control with to prevent distal embolization, because there's not infrequently a little bit of thrombus that occurs around these catheters when they're in these patients that are usually not heparinized. And then as you pull that out, that thrombus can unravel and embolize distally in the internal carotid artery and into the brain. So we worry a little bit about that. Fortunately, most of these can be repaired primarily with just a suture. So the suspected carotid injury with a large vessel sheath, in my opinion, generally should be managed with surgical exposure, except in the extremely high-risk patient otherwise. If it is in place in the subclavian artery, these misadventures may be managed with closure devices, and you can either pick one of the suture-mediated closure devices or one of the collagen plugs. And my colleagues have reported several series of these, and there's some good things that they pointed out during in this paper, including the use of femoral access for both diagnosis and balloon control, and then using a KMP catheter or wire exchange to do imaging prior to application of the closure device. So in conclusion, I would suggest that endovascular techniques are increasingly being used for great vessel trauma. Thrombosis and associated bone and nerve injury are usually best managed with open repair. Stents should be avoided under the first rib if possible. Many blunt and carotid and vertebral injuries can be managed with no intervention other than antiplatelet therapy, and closure devices might be useful for select iatrogenic trauma. Thank you very much.